So we've had quite a few questions about skin grafting, and there is still one more left. Let's see how we handle this one. A patient underwent split thickness skin grafting, that is partial thickness skin grafting, for a burn injury on the arm. On post-operative day 6, he develops stiffness of the arm during physiotherapy. Question is, what is the most appropriate next step in the management? I think that what they want you to know here is the process by which a graft takes on the recipient site. So let's talk about that just a little bit. Okay. When you pick up a graft from a donor area, full thickness or partial thickness, and put it on a donor site, there is actually no blood supply to the graft, and the graft is a living thing. So the first thing that happens is an adherence of the graft to the donor site, and that adherence occurs within the first 24 hours. And it is helped by a thin layer of fibrin between the recipient surface and the graft. So the first thing that is happening is adherence. Now the next thing is plasmatic imbibition. That means it is picking up oxygen through the fibrin and surviving. There's still no blood vessels. There are no capillaries taking the blood from the recipient site into the graft. So it is depending upon something that is called plasmatic imbibition. And the third thing, this plasmatic imbibition occurs within 24 to 48 hours. And after that, there is a development of the capillaries into it. This is called inosculation. The capillaries develop from the recipient site into the graft, and the graft now gets its own sort of blood supply and survives. So that is what is happening. Now coming back to the question, surgical excision of contracture, I think 6 days is too early for a contracture to develop. Passive extension of the joint under direct visualization of the graft, this is possibly the right answer. This is the right answer. Continue physiotherapy without intervention? Well, you may lose the graft, remove the graft and regraft the area, not an option. So the correct choice would be passive extension of the joint under direct visualization of the graft. So I think that completes our questions on skin grafting. Let us do a short revision. A split thickness graft has less dermis and therefore more chances of contracture, secondary contracture. If you put a graft which is this big, over a period of time it will contract and become smaller. But the take is very good. The acceptance rate of a split thickness graft is much better than that of a full thickness graft. Contrary wise, a full thickness graft has a lesser chance of developing a contracture, but a higher chance of not taking. So full thickness graft has full dermis, better elasticity, less chance of contracture. And if it does develop, if you do have a secondary contracture, the answer would be to release the contracture and put another full thickness graft. Now that I think completes the question on skin grafting and burns. We come to the next one. This actually depends solely upon your knowledge of physiology. Pressure greater than dash millimeters of mercury causes pressure sores. So you have to know pressure at the arterial end of the capillary. If the body presses down and occludes the capillaries, then that area of the skin will undergo ischemia and will end up with necrosis. Normally when we go to sleep, we keep turning from side to side without even knowing it, and that's our body protecting us from developing pressure sores. But if you continue to lie down in the same position or sit in the same position for say more than 2 hours, the skin capillaries will stop receiving their blood supply, necrosis, wound. So that is what they're asking. So what should be the pressure? The pressure at the arterial end of the capillary is usually about 30 millimeters. So your answer will be here. If the pressure is more than 30 degrees, then the patient will develop a bed sore, a pressure sore as it is called.